Hello and welcome everyone to the second of our two-part event series focused on voluntarily stopping eating and drinking, or known by the acronym VSED. My name is Sarah Kiskaden-Bechtel, and I'm the Program Director for the Completed Life Initiative, and I'll be your host today. At the Completed Life Initiative, we promote self-determination and dignity at the end of life. If you are new to our event programming, please feel free to explore our video archives on our website after tonight's event at www.completedlife.org. Today's event features expert presentations from two of the four authors of a recently published book of the same name, Voluntarily Stopping Eating and Drinking, a compassionate, widely available option for hastening death. Today's presentation will take a deeper dive into the clinical challenges that can arise in complex care scenarios, such as the advantages and limitations of stopping eating and drinking by advance directive, also known as SED by AD, and comfort feeding only, or referred to in the book as CFO. Judith Schwarz is a PhD prepared nurse who has provided end-of-life counseling to suffering patients for almost 20 years. Most recently, as the clinical director of End of Life Choices New York, she responds to all who call seeking information about end-of-life options and choices. She and her colleagues at End of Life Choices New York developed an advance directive to stop eating and drinking some years ago. She has guided dozens of persons in the early stages of a dementing disease and their families through the process of documenting future limitations on oral feeding when capacity becomes lost, along with the ability to self-feed. In addition, she has advised and supported many seriously ill persons from New York State and other parts of the country who choose to VSED. Timothy E. Quill, MD, is a distinguished professor emeritus of palliative care and professor of medicine, psychiatry, medical humanities, and nursing at the University of Rochester School of Medicine. He was the founding director of the URMC palliative care program. Dr. Quill has published and lectured widely about various aspects of the doctor-patient relationship, with special focus on end-of-life decision-making, including delivering bad news, non-abandonment, discussing palliative care earlier, and exploring last resort options. We are also very lucky to have Dr. Quill as Completed Life Initiative's clinical advisor. So welcome, Tim, welcome, Judy, and welcome to you, our audience. Before we begin, please be aware that you may input your questions into the chat feature located on the lower right-hand corner of your screen. Please feel free to submit your questions throughout the event at any point, and later on we will turn to your questions for an interactive Q&A with our esteemed panelists. Also, if you'd like assistance with closed captioning, you may toggle on the box located in the lower left-hand corner of your screen that provides captioning for the spoken words of our event today. And finally, one last note about logistics. We will be sharing a recording of today's event with you via email in the next couple of days, so please keep an eye out for that. And without further ado, thank you for being here this evening or wherever you are in the world. And Tim, Judy, please take us away.
Okay, thank you, Sarah. We are glad to be here. I'm honored to be here with Sarah and Judy, and we're going to be co-presenting together, kind of going back and forth pretty fluidly. You know, we're all come from a medical background of one kind or another, and you know, when we use medicine's powers to keep people alive and functioning and living longer, we're doing a wonderful thing. But part of that process is also to keep caring for people who aren't getting better, and some of whom may reach a point where they're ready for death. And that's really what we're going to be focusing on today. I'm going to start by jumping right to that phase of things. So this is of people who might be getting near the point where they are ready to stop, call it quits, and give a quick summary of options that exist for people who are at that phase of life. The first place to go is to make sure they're getting adequate care. And then if they're having bad symptoms, make sure they're getting really aggressive symptom management. Because a lot of times this might be motivated by pain or shortness of breath that could be relieved. But if pain or shortness of breath are getting very severe, one of the last resort options might be to take larger amounts of pain or opioids for shortness of breath. And even if that might hasten death. So we might give large doses to manage those symptoms, because that is really our obligation. Having people die in pain or shortness of breath that we could have relieved is just not fair. Wide agreement that that should be permissible. Second place we go when people are start talking about being ready for dying is to make sure that they have stopped life-sustaining therapies that they no longer are benefiting from. So sometimes these are big life-sustaining therapies like ventilators or dialysis machines, where it's pretty obvious that you have to think those through. But it can also be smaller life-sustaining therapies like antibiotics or fluids that might also be stopped if somebody was really ready. And so we're going to look at those options. And again, widespread agreement ethically and legally that these first options are permissible. Getting a little bit more in the gray area, we might talk about palliative sedation for symptoms that are severe that can't be relieved any other way. So this might be taking risk with our palliative treatments of making people less alert, less responsive. In fact, we might even use palliative sedation all the way to unconsciousness, so people are unaware of their suffering, if that's the only way we can relieve their distress. And again, pretty wide support that this is permissible as long as it's proportionate to the amount of suffering that the person is going through. The next option is stopping eating and drinking voluntarily. This is different from the natural loss of eating and drinking that might occur at the end of life as you're really in the very, very end stages. This is a conscious decision to stop doing that. And this is also a legal option in New York and other states in the U.S. and perhaps all over the world, because its legal status is not really in question. On the more controversial end of the spectrum, physician aid in dying or physician-assisted suicide, if you want to call it that, not legal in New York State where we live, but legal in 10 states in the District of Columbia and all of Canada, and also legal in the Netherlands. So again, this is where a clinician would make available to a patient a medication that could be taken if it was taken all at once in an overdose that would intentionally hasten death. So physician or the clinician is the prescriber, but the patient must finally take the medicine with his or her own hand. And this is with the explicit intent of hastening death. And again, legal in 10 states in the US and DC, but very controversial, I think, elsewhere. And then the final option is voluntary active euthanasia. And this is where a person is wanting to be no longer here, wanting to be dead. And here they may not be able to self-administer, or they may want a clinician to self-administer or to administer the medicine to them that would cause their death. Again, this is much more controversial in both legally and ethically in the United States, but legal in the Netherlands and a few other places, but really much more restricted internationally. So let me pause and let Judy comment on this overview and fill in some of the loose ends.
I would just say, speaking as somebody who works primarily with New Yorkers, that VSED, voluntarily stopping eating and drinking, gets a lot of attention and a lot of interest because it's the only legal option for patients who want to be able to control the circumstances and timing of their death. I can tell you it's nobody's first choice. They would really rather have, you know, the euthanasia thing with somebody just taking care of things for them. But when they come to understand that that's just not possible in New York State, that there is no medical aid in dying, and yes, I know we should pass a law and we're working hard to do that, but until we can, VSED is the next best option for people who have no better alternatives. And I'll tell you, even, and I think Tim would agree, even in states that have medical aid in dying, VSED often gets used by people who presumably have the option of acquiring a lethal amount of medication. There are lots of reasons why people would rather have something that's closer to a natural way of dying than doing that very dramatic quaffing the hemlock, as it were, because that takes a different kind of energy and attention. So that's really all I want to say. The other thing, although I will add to that, that the palliative sedation business, people hear about that and they think that they can just sort of call up their doc and say, okay, now I'm ready to be put to sleep because I'm really getting tired of all of this. That's not the way it works. This is an option only when all of the other usual things that are done to palliate symptoms are not working. And it also often requires the patient to go from their perhaps home hospice bed back into the hospital. Is that not true, Tim?
True.
Where often these medications are provided either by IV or subcutaneous infusions, and they require skilled clinicians, and it's not just giving more morphine and thinking that that's going to cause them to go into a coma. That's not the way it works. If you've been taking opiates for any length of time, you develop tolerance to them, and they're very, very, very unlikely to cause death. That's it.
Okay, I would ask you as listeners, if you have questions about any of these options, save them a little bit, and we'll be entertaining questions as we go along. I'm going to go a little bit in more depth about voluntarily stopping eating and drinking, just to make sure that you understand exactly what this is. So this is really a conscious decision by somebody who is physically still capable of eating and drinking to really stop entirely eating and drinking in order to hasten death. The stopping eating is actually relatively easy. Of course, easy for me to say, but because you get ketotic, which means your body starts to generate ketones, which takes your appetite away, and that makes it fairly easy to do. But the stopping drinking part of this is super hard because you get really thirsty, and our means for palliating the dry mouth and dryness that one gets is limited. It doesn't work all that well. You swish stuff around. There's artificial saliva. You spit it out because if you swallow too much of it, it really prolongs the process. Now, the benefits of VSED is it's really available to just about anybody who wants it. So you don't actually have to have a imminently terminal illness to do it. You could, if you had a serious illness, you might not need to have a huge amount of medical support, although I think it is wise to have good supports, both medical and nursing and family, to do it. It takes a while to achieve. That's a plus and a minus because it takes about 10 to 14 days from beginning to middle to end. The good part about that is that's a good time for families to come together, to say goodbye, to say you love them and all that good stuff. But if you're having bad symptoms, that's a hell of a long time. And I think that's too long. It also requires that you have to be a very disciplined person. So for a person who's not super disciplined, super controlling, I think it's really hard to do. And you also lose capacity to make decisions later on. So then your drive to continue to stop eating and drinking may fade because you can no longer remember why the heck you're doing that potentially. So you really need to think that through, talk it through with your caregivers, and maybe even fill out a document that says, really don't give me stuff because I really don't want it, even if I'm saying I want it later on. So those are some of the elements of VSED. And now I'll turn it over to Judy to talk about how much can we do this by advance directive, perhaps.
And I will do that. I just want to add one thing to what Tim said about VSED. Because it's likely that a patient will lose capacity and will forget what the plan is, because that's predictable, Before the process is begun, the patient and the family and other caregivers need to have a plan for how they're going to respond to the patient seeming to indicate they want something to eat or drink. And that should be patient-driven. And there are some options that we're going to talk about because they become very important in the advance directive to stop eating and drinking. So what is that? It's a newer phenomenon. It's not quite as widely known as VSED is, and we're here to tell you that not everybody knows about VSED. So the definition of an advance directive to stop eating and drinking is a very specific kind of written directive that's completed when the patient still has very clear decisional capacity, and they decide that at some point in the future, they're going to want their fluids, their hand feeding, and all provision of food and fluid limited. And they get to choose, while they're still decisionally capable, when those limitations should be imposed. There are clinical triggers. Most often, a patient will decide, you know, when I lose capacity, when I don't recognize my family members, when I don't know who the heck I am, I do not want to be kept alive. I don't want my dying prolonged at that point. So at that point, that's one of the clinical triggers that says, okay, now you implement the choices that I've made. So the clinical triggers that you get to choose ahead of time are the manner in which you want fluids limited. Now, some people who are very, very determined to not have a prolonged dying process once they become advanced demented rather, will say, I don't want any food or fluid. Do not give me anything. And of course, that would require them to receive very aggressive symptom management, palliative care by a clinical partner, and that needs to be worked out ahead of time as well. But often, that's very hard for family members to support, basically, because they may worry that their loved one, who can't communicate clearly anymore, is still hungry and thirsty, and maybe they're indicating in some nonverbal way that they want to eat or they want to drink, and they certainly don't understand why they may have a really uncomfortable feeling in their mouth. So the choices that are available under the rubric of something called comfort feeding only, which is certainly well supported by hospice. Comfort feeding only is giving that patient as little or as much as they seem to want, no more, no less, and they decide. And that's what gets respected by caregivers and family members. The other under this rubric of comfort-focused feeding is something called minimum comfort feeding only, which has sort of two goals. On one hand, you do want the patient to be as comfortable as you possibly can make them, but at the same time, you want to give the least amount of oral intake that's necessary for comfort, but at the same time, trying to facilitate their desire for a hastened death. So, those are those are basically the three options for limiting oral intake that you can write down, and you must write it down, and you must write it down very clearly. And you must also indicate who's going to be the person who's going to implement the choices that you've made, that you've written down very clearly. And ideally, that's going to be an appointed healthcare agent or some other surrogate that you've identified who knows your wishes, understands what the wishes are in terms of limitations, and agrees to implement those choices and advocate for your wishes when you've lost capacity. So that would be advocating with caregivers and with clinicians and anybody else that's going to have an opinion about this. Ideally, again, in addition to an appointed surrogate or an agreed upon surrogate, you have family members who understand the wishes and that they will agree to support them. There must be many copies of this written advance directive that are distributed widely to all of the stakeholders in this patient's life, everybody that cares about this person, including, obviously, the clinicians, the physicians, the nurse practitioners, anybody who's going to come into contact with that person. So I think that we should also include the benefits and the limitations of this. So the benefits of an advance directive to stop eating and drinking is that the patient who completes this has peace of mind. They know that they've done the very best they can to communicate to caregivers in the future when they're not going to be able to be directed to care what their wishes are. And they're able, therefore, to live their life as fully as they can and in not worry about getting caught because they have written a plan out that they have support for. As I said, the other benefit is it limits the length of the dying process once the dementia, in this case, enters an advanced stage. The limitations on the use of an advance directive to stop eating and drinking. As I mentioned, it's really, really challenging to palliate the symptoms of a dry mouth, for example, and other symptoms that may arise when fluids and food are being limited. The patient can't cooperate in any of the rinsing and spitting and the stuff that we have identified as being at least minimally comforting. So that can be really troubling, and the patient's not going to remember that they completed an advance directive. They're not going to know why they're feeling the way they feel. And this is difficult for family members. This can be really distressing, and particularly if they've said, I don't want anything. Family members often will err on the side of comfort-focused feeding. So maybe it prolongs the dying a little bit, but at least they know that their loved one's not suffering from food or fluid in a way that they can't tell them. The other thing that you have to keep in mind is this is a difficult directive to have honored in many settings, like, for example, long-term care settings, institutional settings that are just not familiar with the concept of completing a directive to stop something that seems so basic and to some people doesn't even seem like it's medical care to be feeding somebody. However, there are, and I'm not a lawyer, but there have been lawyers that have said if you're shoving a spoon in somebody's mouth, that's the same treatment as putting an IV in them. I believe that was Rehnquist, wasn't it, Tim? Chief Justice.
I remember.
Anyhow, there are definite challenges to this. This is a newer document. I don't think that it has come before a judge yet. No doubt it will. But we're hoping that it will get treated like any other advance directive that says, I've thought about this a lot, and this is how I want to be treated when I'm no longer decisionally capable. So that's the end of my statement.
All right, I'm going to go back a little bit and do a little catch up here because we want to make sure we understand, or I want to make sure that you all understand the benefits of VSED itself. And one of the benefits is that the patient is the one really in charge. You know, and unlike almost any other end-of-life treatment, patients are not that much in charge. But the patient also needs family involvement in most cases because this is a process. It's going to take some time. Another plus is there's a time where you really have capacity. So in the true hospice sense, there's a time to say goodbye to your family. And unlike the kind of situation where you don't know if this is going to be 6 months to say goodbye, if you're doing VSED, it's really going to be 10 days to 2 weeks to say goodbye. So there's a beginning, a middle, and an end. And that is, if you're ready, that's a good thing for everybody. Families can come together. People can take time. Some people can take time off for that kind of time frame. And it's different from an open-ended commitment in that sense. In the early going, patients can change their mind. You know, they can rethink it, and that's okay. Although you really want that to be part of a conversation, because if they change their mind, then go back to it, and change their mind and go back to it, it starts to go on for a very long period of time, which is okay if that's what the patient wants. Another plus of VSED is you don't really need to have an imminently terminal diagnosis. So it is an option for people with serious chronic illness, perhaps somebody with warning signs of dementia, and they're worried about not wanting to go there. They might have other kinds of chronic debilitating disease, and they're really tired of continued living under their current circumstances. they can have a conversation about VSED and where they wouldn't qualify for other potential life-ending options. You don't have to have overwhelming symptoms to get VSED, right? This is something that you could choose even if your symptoms weren't that bad. Maybe you were more worried about the debility or the need for so much care rather than overwhelming symptoms. VSED is also legal. There's no states in which VSED is illegal. So you don't have to change the law. Now, again, it hasn't been carefully challenged, but it would be, the challenge would be to force feed somebody who was super sick, who didn't want to eat. And that doesn't seem like a very appealing legal pathway. VSED is similar also to natural dying because in so-called natural dying, if people are eating whatever they want, the late stages of that, people generally stop eating and drinking gradually. And VSED is very similar to that. And finally, people have been dying this way for generations. This part of the how much is willful and how much is natural has been an ambiguous part of the dying process, I think, forever. And this is just acknowledges that sometimes people want to take more charge of it and set more limits on it because it's going on too long. There are some definitely unique challenges that are going to be part of VSED, and one is dry mouth. So that's going to be there, right? If you're not eating or drinking, particularly not drinking, your mouth is going to be dry. There are ways to palliate that. Artificial saliva you can put in your mouth and spit out. And that can be hard not to swallow it, but this can be done particularly while you have capacity. In the late stages, a little more tricky. Delirium at the very end of this is going to be almost always a part of it. So people get very weak, their electrolytes get out of whack, they get dehydrated, and eventually they may get somewhat confused. Now, again, if they're confused in an uncomfortable way, we can certainly provide sedation. But some part of that confusion may be saying, I'm really dry, I want something to drink, without thinking through that is potentially going to prolong the process. So that's really, I think, a challenge of this. And on the other hand, also people might change their minds. So I've known of patients who have started this a few times and stopped and decided they wanted to keep living for a while longer, and then started again and stopped, and then eventually carried it all out. But that does have the option of doing that, and there's nothing wrong with that if that's what a person decides they want to do, because these are big life and death decisions, and you want to make sure people are sure. So any other challenges, Judy, we should cover before we cover a couple of more matters?
No, I think that really summarizes the pros and some of the challenges with VSED. It's interesting, Tim. I've never had anybody start and then stop VSED. It's really interesting, the different experiences that we have with this. And because I think that there's a lot of emotional and spiritual heavy lifting that has to go into thinking about this and then choosing, because you're choosing a date to start this process. And each day you get to decide whether you're going to continue. And that is something that you, almost without exception, are talking over with your loved ones, with your family members. They don't want you to suffer. Maybe they don't want you to die. But on the other hand, they also know that you are suffering in ways that you're finding unacceptable. And most family members that I know are able to put their own sort of grief aside and support their loved one through this process. And as Tim said, it can be actually kind of a wonderful time. I mean, there's sharing of memories, it's inviting old friends in to say goodbye. And often if you're in hospice, which of course VSED, if you have a terminal illness, VSED is well supported by hospice. You don't have to acknowledge that you've made a choice to hasten your death. You can just say, I'm not hungry, I'm not thirsty. And that's what many, many people will do. As Tim said, and I think it's important to reiterate, people have been dying this way forever. And I often find when I'm talking to a patient about this, they'll pause and say, I think that's how my grandmother died. There's a lot of this that's happened for quite some time. And generally speaking, It's a peaceful, gentle kind of slipping away death that occurs over time in a setting that the patient chooses, which I think is also important. So that's all I have to say about that, Tim.
And also for some of the conditions that are not imminently terminal, where people might think about VSED, for example, early signs of dementia, where somebody maybe has a family history and they're worried about what that's going to look like down the road, they can have a lot of time to think about this in advance, to talk it over, and it gives them an option to not go through what they're worried about. But there can be counseling, there can be second opinions. And even if they wouldn't qualify for hospice right at the start because they're not terminal enough, they're not more likely than not to die in the next 6 months. Once the process is underway, usually most hospice programs will support the patient and family going through this. Again, not all, but most would. You know, these challenges that are common to both practices, you know, it's 10 days to 2 weeks duration. If you're well hydrated to start in with it, you definitely need caregiver support. It's really hard to not drink if you're really thirsty. Not eating is much easier. Just to summarize, you get ketotic, and you generally lose capacity late in the process. And you may lose your ability to participate over time. So sedation may be part of the process later on.
Right.
So maybe we will pause here and see if there are questions from the audience, and then we're going to get into some cases.
Thank you, Tim. Thank you, Judy. Enlightening discussion today. So there's a couple of questions. One is from Sally. She's wondering, what is the acceptable Medicare diagnosis for hospice if the patient is not within the last 6 months of life? Sally, perhaps you might clarify your question in the chat. But briefly, any thoughts, Judy or Tim?
I'm sorry, I didn't hear what you said. You were breaking up a little bit, Sarah.
I think I understand what the question is. What if a person isn't, if the disease follows its usual course, you have to be more likely than not to die in the next 6 months to get into hospice. That's the criteria from a prognosis point of view. If your condition is early dementia and you're worried about late dementia, you don't meet that criteria, at least before you start to VSED. So you have to wait for later on. And there are other conditions that you might, other chronic illnesses that you might not meet the hospice criteria. But usually once you've started the process, then your prognosis starts to get limited. So you qualify, you could theoretically qualify for hospice. Again, hospices vary on how open they are to this question because this is intentionally hastening death, and hospice, you're not really supposed to do that. But the people who are doing this generally are quite sick and quite debilitated, and so that is very common to hospice and quite a good fit for hospice. So again, our hospice, if people, once they've started it, hospice will quite readily get involved and provide really good support, and it's very helpful if you can get them involved.
Let me just add to that, Tim. I find that when I'm working with patients who are considering VSED down the road, they're not quite there yet, but they've got a lot of chronic comorbidities. They're getting elderly, they're getting frail, and they're recognizing that there's going to come a time that they may just decide to stop everything. I tell them to start talking to their clinician right now before they're even close to that, so that their physician knows that they've been thinking about this and that there may come a time when they decide to stop everything, stop all of their life prolonging measures and the pills and the whatnot. And that at the time that they make that decision, that they really trust that their clinician will honor their choice and get them into hospice. And I encourage them to have that conversation every time they see their physician for their regular check-in. Be sure that they remember that. Be sure that they understand that this is what you're going to want and that they will partner with you down the road.
Yeah, I think there's a testing the water conversation. If somebody's beginning to think about this, think they might want to talk to your primary care doctor,
Yeah,
to talk to your
yeah.
main treating specialist,
Yeah,
and see whether they're open to this idea. And if they are not, then and you really want to have this as an option going down the road, then it may be worthwhile looking around, trying to
yeah,
find again. You can look for an advocacy group like Judy's group that might be able to help you identify somebody, or just asking your own group of friends, group of clinicians that you might know. But finding a partner is really important, and
yeah,
somebody who's an open mind to this if it's something you would like to have.
yeah.
Thank you both. Barbara is wondering if one chooses VSED due to early dementia, what can trigger access to sedation?
What can trigger what?
Access to sedation.
You want to take that one, Tim?
Yeah, it's tricky. I mean, mild sedation, anti-anxiety medication, I would say proportionate sedation is going to be pretty accessible. So if a person was agitated, if they were really anxious, I think they could easily gain access to those treatments. Now, again, if it's early dementia, the risk in general, you try to avoid those medicines because they may make your confusion more. But at this stage of life, then I think the trade-offs may be able to be made. And if you get more confused, more agitated, then you can get more medicine. But these are kind of gray areas where you really want to have some conversation with your treating people and make sure they're committed to keeping you comfortable, so that if you begin to have these things, in my own personal opinion, if a person is dying, nearing the end of their life, and they're starting to get more agitated, then proportionate sedation is clearly indicated. And if a little works, great. If it doesn't, then you need more. And you may even need sedation to unconsciousness if the agitation gets a lot worse. And that's, people have died this way. This is part of how it goes at the very end for some people. And you want to make sure your providers, your clinical providers, are not afraid to be pretty aggressive if that's what it takes.
The other thing I often tell people, particularly in the early stages of a disease like Parkinson's or dementia, where you know that they're going to lose capacity down the road, ask for a palliative care consult. See if you can get a palliative care clinician involved early on in your symptom management who will be more likely to support a choice to stop everything. Wouldn't you say, Tim?
Yes, I would say. I would say it's 100%, but
it's more likely to be a higher percentage than your average GP.
Yeah, and also they have palliative care people have more experience than average doctors in managing symptoms and discomfort, and all that stuff, and you want to have that to be maximized.
Yeah.
So it's good to have that person as part of the team. They may be more of a consultant, more providing input to the primary care clinician, who can then implement most of it, or they may need to take over if it's a particularly tough case where there's a lot of agitation and other problems.
Thank you. Pamela is wondering if you can comment on the nursing care needed in the final 2 weeks for a patient dying by VSED.
I can certainly talk about that. I say to family members that family members can't provide 24/7 care. It's just too exhausting, and it's emotionally exhausting as well. It's not that these folks, for one thing, every person's going to be in bed. They're no longer doing the dishes or planning meals anymore. Once they stop eating, they're going to become very weak. We don't want anybody falling down and breaking a hip. So they have to realize that if they make this choice to stop eating and drinking, they're going to end up being in bed all the time. So there's going to need to be the kind of physical care to keep them clean and dry in bed. Now, often that's going to require an aide. Now, how many hours a day you need to hire an aide to provide caregiving support so the family can take a break, can leave for a while, that will be up to the individual family. How many members of the family are available to help out, because this is hard. It's not technically demanding, but it can be emotionally pretty demanding to be there and to be available, particularly when the patient starts becoming a bit delirious. You're going to need to have a clinical partner who will order medication for you that you can have at the bedside, so that the family and or the aides can give them the small amounts of liquid anti-anxiety medication or anything else that's necessary to keep them comfortable, semi-sedated, sleepy, and comfortable. So you certainly don't need an RN. It's great if you can get into hospice. That's the best way to have hospice oversight. But then again, word of mouth, because there are wonderful aides out there who do this work regularly. They do it very well. And the other group that should be included is I know that doulas are doing a lot of this work now, and that's also another option to consider. Although in any case, so it's something to explore.
So it's also just I'm a big believer that it's a time for families to come together with this. I mean, this is the last 2 weeks in theory of a person's life, and it's radically different than if you've been in this declining process of pre-dementia for 2 years, and people are kind of riled about it. There's suddenly an end in sight, and it's a time really, there's some real opportunity for coming together during this. Now, again, maybe I'm too romantic about this. I don't think it's always kumbaya and wonderful, but it can be. And there can be moments that people really treasure, and so getting and also getting everybody involved, the kids, the grandkids, and all that stuff is also really important. Kids, if we don't get them involved, then they're going to be like, this isn't about life. This isn't about me. This is for the little people, who are mortal, and in fact, we're all mortal, and learning about that is something that can come out of these things that is a good. It's not easy, but it's good.
I would also encourage the boys to be involved as well, not just the daughters, but also the sons and the grandsons and the nephews. And I don't mean to sound sexist, but often this gets delegated to the female members of the family. And this is not rocket science. It's not really technically demanding care. And if you have some additional supporters who can do perhaps more personal care, there's room for everybody. And I totally agree with Tim. This should be a time that this family can look back on it and feel like they did everything that their mom or their dad wanted them to do, and they were able to keep their loved one in this environment of love and support. And I agree. I think there are wonderful memories that can be had at this time.
This is also why, even if the person doesn't qualify for hospice at the start, if they're really into this, they do qualify, a third of the way through. If they're really committed, they're not eating and drinking. Again, most hospices will then take them on at this point. Not all, but most will, and that's hugely helpful, because then there's somebody you can call besides the primary care doctor or whatever if you have trouble, and they're also very experienced with this phase of life, and so getting them involved is very helpful.
Yeah.
Absolutely. Thank you. So you've described the ideal situation of having the family show up and having this moment of reunion. But for the case of no family being available, or perhaps not available for 24/7 care, as Gisela mentions in the chat, during the VSED process, what are the practical options for paying knowledgeable people to support a patient through VSED?
Well, there are certainly agencies that you can approach to hire aides. I would really recommend you survey your friends in the neighborhood, because everybody who had good experience with an aide has that name down and their phone number and how to get a hold of them and their email address. And then I tell them to ask if they have any relatives who are available, because if you've got some member of a family who provides wonderful care, they've taught other people how to do that too. And you're buying the philosophy. You don't want somebody who feels it's their job to feed them and feed them up good, whether they want to be or not. That's not the goal here. And it's hard for some for some caregivers to pull back from that and understand that they're implementing a choice that this patient made, and it's respectful to honor that choice. And if they can't do that, then they shouldn't be hired to care for this person. But it's absolutely true. Not everybody has a family that can come in and rally around, but there are hired aides that can be the other group. I just thought often hospice has a stable of aides that moonlight, and ask, once you get into hospice, ask the nurse whether there's a list of aides that have been sort of hospice trained and are available for hire. Because if you can hire off the books, it's not going to be nearly as prohibitively expensive as some of the agencies. And the agencies have lots of limitations about what the aide's allowed to do and not allowed to do. And I have very little patience with that, but I understand that that's part of how they have to operate.
Just when you are hiring aides and other people off the books, really, if this is what you're trying to accomplish, really interview them in the early going, because this is different.
Yeah,
and,
yeah,
and
yeah.
It's off the usual hospice approach, and a lot of the folks that you're hiring in this way are masters at getting people to eat and drink, and that's a wonderful thing in the right circumstance, right?
Yeah.
In this circumstance, it's not a wonderful thing.
Yeah.
It goes against the grain, and it may really undermine the process. So a careful interview, make sure they understand what's happening. And if they're not, then I would strongly suggest not hiring them.
Absolutely. Absolutely.
It's going to undermine what you're trying to accomplish.
Yep.
Thank you. I'll turn to one last question before we get back to your case studies. So this question is from Jean. She's wondering if you could discuss briefly the specific ways to help with dry mouth and how a caretaker can help with the issue of dry mouth.
I could talk about that. So while you have a cooperative patient, while you have somebody who can follow instructions, rinsing cool water through your mouth and spitting it out often, frequently, is just the best thing to do. The next best thing to do is getting one of those plant mist sprayer things and get a fine mist that you spray into the back of the mouth. And then the other thing you can do is take a washcloth, wring it out with cold water, put it in the freezer, bring it back out, and that's something that they can keep in their mouth. It doesn't have a lot of water in it, but it's soothing and comforting. Also, you want to be sure that the patient's teeth and gums are kept clean and not gummed up with any kind of yucky stuff. So even if the patient's not totally awake, you can take a washcloth and put it over your finger and go over their teeth and their gums. You can dip it in a little mouthwash so it's freshening and not something, as Tim said, that they're going to drink. You try and you see what works best for that person. I don't like ice chips at all because you end up drinking a whole lot more fluid than you ever realize. And I also think there's a rebound thing. All of the blood vessels clamp down when you've got the ice in, and then as soon as you've swallowed it, they expand, and I think it makes you more thirsty. My opinion. I don't know whether it's physiologically sound, but it's a lot of experience.
Yeah, I think this is the trickiest area of this process, because dry mouth is a tough thing, and if you give a lot of ice chips or a lot of anything like that, it really prolongs the process. And that's, if that's okay, that's okay. But if for people who are really wanting to have it be over with, then you have to really think carefully about what you're doing and how much you do, and try to keep it to a minimum, because I think it's tough.
All right, thank you to our audience for the questions, and please continue to submit them, and we'll circle back to your questions after Tim and Judy explore their specific cases for today.
Before we get to that, I just want to say, getting back to the directives to stop eating and drinking, in addition to drafting as complete a directive as you possibly can about what your wishes are, what kind of limitations you want implemented, and when you want them implemented, what clinical triggers should be in place, and who's going to implement them. I recommend that you make a video. If you make a little video of yourself while you're still decisionally capable, obviously, explaining to whoever is watching this why you've made this choice, what your values are, what your concerns are, and what you're hoping to accomplish in writing a document, that it's not what many people are familiar with. You're helping a future caregiver implement your choices with less angst because they now understand, oh, I see now. I understand why you made this choice, and I will do everything I can to try to honor that. I think it's also very reassuring to family members who may forget because they get caught up in trying to do caregiving rather than respect the choice that's been made. And this can be reassuring and confirming, basically. And also anybody that's concerned about the legality of elder abuse, God help us all, to have that kind of documentation that's really contemporaneous at the time, I think is a very helpful thing to do.
Just one caveat on that. Get somebody else to read it who's got experience in this, because you can say things and things that really are very undermining to the process. So you know, find somebody who knows, who's thought these things through, and have them read through whatever you came up with. And if need be, have a conversation with somebody like Judy, who's got a lot of experience drafting these kinds of things.
Yeah.
So I think we're shifting gears to a couple of cases. Is that what we're going to do, Sarah?
Please, and thank you.
All right. So we have a few cases we're going to start with, and we'll keep going. And if you guys have cases also, we'll get to those as well. The first case was I'll present, and this was a patient who was a mother of one of our esteemed palliative care providers who was developing signs of dementia. She was able to live at home at this time. She definitely did not want to go to a nursing home, but saw clear signs of dementia, which also ran in her family. Her son, who was my friend and colleague, was in conversation with her, and he clearly wanted to support her, but being her son, he also knew that he needed to get a doctor who was a little bit more distant from the process to participate, which is why I became involved. We had a couple of meetings, and it was clear in reviewing her medical records that she did have early signs of dementia. She was able to be independent for now, but this was gradually being lost, and it was getting progressive. She also had done a lot of the work of getting prepared for dying. So we talked about the stopping eating and drinking option. We had a couple of meetings. I actually had her see a psychiatrist just to make sure that she was thinking clearly at this point. Maybe that was overdoing it a little bit, but again, we wanted to make sure all the T's were crossed and the I's were dotted. And that psychiatrist felt that she was capable of making a big decision, like stopping a life support decision, which this is of that same level. And then she set a date and eventually stopped eating, drinking, was able to be managed at home. Doing this, she became gradually weaker and actually had a quite wonderful death at home from stopping eating and drinking. The process took slightly under 2 weeks to occur. She was quite alert for the majority of the process. She did have an advance directive, which said she didn't want any aggressive feeding or fluids if she lost capacity. And so we were able to follow her wishes quite smoothly till the end. And we got hospice involved about 10 days into the process. Hospice was supportive at this point. And again, she stayed at home until she died. So that would be like, I think, a paradigmatic case of this. This is in the ideal world sometimes does really occur. But I think this ideal world had a lot of good planning, had somebody who really knew what she wanted, and got a lot of good advice about how to accomplish what she wanted. So any comments, Judy, or others, or questions about that case?
No, the only thing I would say is that the trouble with some of these cases is it can lead people to think that they have to have all of these moving parts in place in order to succeed. And that's not the case. The other thing, I've spoken to dear friends who say, this would be hard for many people to be able to afford to have caregiving help for 2 weeks before they die. My goodness. And that's true. We're making recommendations about what we think best practice is that would most likely facilitate. I never talk about good death. I talk about the least bad death possible. We want people to be able to have good memories of this time. We want people to not have to suffer in ways that they find unacceptable. And we want the family to be, if there's family, there might be just close friends who can come together at this time. So you may not have all of those things that Dr. Quill's case involved, and that's okay. But you do need help, you do need support, and you do need a clinical partner. So however you can make that happen, you'll find your way if this is something that you feel is right for you.
There is also in most hospices, and of course you may not know this if they're not in hospice going into it, but there's an emergency pack in hospice that goes in so that you, and this would be an example of, and we did this for this person, we provided some very concentrated liquid anti-anxiety medication, very concentrated liquid antipsychotic medication, very concentrated liquid pain medicine, so that we, even though she did not have a lot of symptoms at the start, we were at the ready should those symptoms occur. And again, likely there's going to be some confusion. And if there's confusion, there may be some agitation. And you want to really, in my mind, in these circumstances, you're erring on the side of comfort because that's what she wants. She's trying to die a comfortable death. And as long as everybody's on board for doing that, provided you're well prepared. But these things have to be in the home, because if the agitation occurs in the middle of the night, you're going to have a hell of a time making it happen. And then they go to the emergency room, and that's just all hell breaking loose potentially. So we really want to try to keep the person home if at all possible, which means you have to be at the ready with a lot of these concentrated medicines in case you need them. You may not need any of them.
Mm-hmm. It reminds me, Tim, of a case that I had of VSED where the woman had a husband who had chosen VSED 5 years before. And I had helped them as a couple go through this process. And he had had some delirium in the middle of the night. He called me, and I did exactly as you said. I said, there is a medication in the refrigerator. It's called blah, blah, blah. Open that up. Give it to him right now and call hospice immediately. And she said, oh my God, it worked. It was wonderful. Thank you so much. So that when she came to the point in her life where she decided she was done, she was done. She had too many chronic comorbidities. She was finished, but she had a longtime physician who'd been through this process earlier with her husband, who supported her, who was happy to order medications to have in her house. And her son and her daughter arrived from who the hell knows where they were, way far away, and it was in the middle of COVID. So there was lots of anxiety about having strangers in the house and how is this going to work? It worked. Find a way if you've got people coming together saying, how can we solve this problem? The one little bit of a wrinkle that I thought was quite interesting, she hadn't seen her son and daughter in person for a long time. So they got in their cars, drove from the west, spent time with her mom, went through all of the papers that she wanted to show them, told them all of her plans. And the son and the daughter call me and say, I'm not sure whether she's going to, how soon do you think she might, because we have to get back to our families and our jobs. And I said, you know what? She needs this time with you guys. And when she's ready to, she will. And she did. And it went just fine. But this was just staying at home with her son and her daughter, caring for her because they didn't want anybody else in the house in the pre-vaccine COVID days. And it went fine. And the doctor signed the death certificate and everything was good.
I noticed in the chat there's a question about VSED being attempted in a nursing home environment, and I will say it really depends on the nursing home.
Yeah.
Because not only do you have to have the docs in the nursing home on board, but the aides, bedside people, and their whole mission generally is to help people eat and drink better. So again, it can be done, but it's hard, and a lot of times we've had people be discharged to home or to a comfort care home from a nursing home to VSED because the nursing home just wasn't a reliable place to do it.
Which is really a shame because that's been their home and they should be able to stay there where they're comfortable. But
there are nursing homes that can do it if the people are on board. So let's do case. Oh, go ahead, Sarah.
We just had a couple more questions for you before diving back into the stories. So Lori is wondering, what preparations do you recommend for gradually reducing food intake and then fluid intake? Many people don't know that you can't just eat one last huge meal and then stop eating and drinking the next day. What do you recommend in this situation?
I've had patients do that. They go out and have one last celebratory meal in a restaurant. It's up to the individual. Some people feel they need to taper off their food and maybe taper off their fluids. Others look at the calendar, choose a date, and say, that's when I'm going to begin. I don't think there's any right or wrong here. It's what seems most comfortable for you. But I don't have a lot of experience with people tapering down. That doesn't mean to say that it doesn't happen. But what do you think, Tim?
Well, there's the natural tapering down that comes with comfort-oriented feeding. So if somebody's been on a comfort approach, and depends on how much if they're eating like crazy on a comfort approach, then the mountain they may have to climb may be a little bit bigger than if they don't have much of an appetite to do it. But I think it can be in either case. There are people who have a celebratory meal and then stop, because the people who do this tend to be very strong-willed people. And so that really allows them to climb some of the minor mountains you have to climb along the way.
This is not for people who are having a bad hair day.
Well, it has checks built in, right? Because it takes a while.
And you really need to give it a lot of thought ahead of time, and you need to have a plan, and you need to have support. So this is not for impulsive people. This is, as Tim said, this takes thoughtful planning and a resolute will to be able to control the timing of your death.
So shift to case 2, Sarah, or we have other questions that need attention.
We have a couple more questions. We can zip through and then turn to the next case. So a couple of people just had a couple clarifying questions. One is wondering, was hospice only there for a few days, and what kind of palliative medications did this woman require? Your thoughts briefly?
Go ahead. You start.
Yeah, I mean, once hospice gets there, they'll generally stay, even if you have some fits and starts with the process. They'll stay if they've come in the first place. So again, usually they're there for a week, 10 days. In these cases, if somebody really stops eating and drinking, if they have a lot of fits and starts in it, so they start and then they stop and start and then stop, that's not unfamiliar terrain for hospice, for most hospices. It may make people a little crazy because they're not exactly sure where they're going. And if the person didn't really have much of a terminal illness or terminal condition at the start, then I think that's more ambiguous, because if they really are going to start and stop, then they need to probably go off of hospice until they make up their mind that they really want this. And if they don't, and that's okay, it's not a problem to do that.
Well, I would just add to that. I've had some challenges getting patients who have no terminal diagnosis. They may have a lot of chronic illnesses. They may be feeling like they're done, but that's not what hospice needs to put on the papers to get Medicare reimbursement. And Tim, I think, is a bit more positive about the likelihood of being able to get somebody into hospice when they stop eating and drinking. That's nothing you can put down on the diagnosis thing for terminal illness, that they've decided to hasten their death and they're not eating anymore. So I would say it's a little bit more challenging sometimes. I'm not saying it can't be done, but it needs careful planning and some backstory preparation and families to come together and figure out the best way to do this.
So some chronic condition and then failure to thrive.
That's no longer working, Tim.
Well, it works in our community.
It's off the hook.
It works in our. It doesn't work as the sole thing. It has to go with some other conditions. But again, this is all, if they start to thrive, they'll get kicked off of hospice. That's just.
All right, thank you. So Tim, let's proceed with your next case.
Okay, so this one's a little bit more difficult. This is a man who had a cancer that was quite significant, and he had a fair amount of treatment. It was a head and neck cancer, made it hard to eat and drink to start with, but he had really had it. And he was somebody who really desperately wanted physician-assisted death. And actually that's how he became my patient, because, you know, I had written about this subject and he thought, well, I'd probably be a good doctor and I'd go underneath the radar screen and probably help him out with this. But at the time that he was my patient, I was really too much in the public eye around these kinds of things. So I couldn't do that even if I wanted to. I'm not sure I would have done it anyway. But so we had to come up with what are his options. And his only option, really realistically, was stopping eating and drinking, which when I first presented this to him, he thought this was the most barbaric thing in the world. He thought it was just horrible to do. And I apologized. I said, it's not ideal at all. And in certain ways, I suppose you could think of it as barbaric, but it does work. And so he stewed about this, but eventually came to grips with the fact that it probably was his only option. Didn't have a lot of pain, so we couldn't treat him with a lot of pain medicine. He didn't have any shortness of breath. And he stopped eating and drinking. He was mad most of the time that he couldn't have what he wanted. Maybe he was a kind of a mad guy to start with, but this fed right into that part of his personality. But he was also extremely strong-willed, which is a good quality to do this. And he died in about 10 days of doing this. He was really adamant about stopping once he stopped, and we were able to palliate his symptoms quite well through it. We couldn't palliate the miffness that he had at us for not helping him in the way that he wanted, but otherwise we did a pretty good job.
So I've got a case about a woman who could neither wait to do VSED, nor could she wait to implement the advanced directive to stop eating and drinking she implemented. This was a wonderful woman who was a retired university professor who moved from university housing down to a pretty high-end retirement community where she thought she'd find other like-minded retirees, academics, and she was looking forward to setting a new group of friends. Although she had early dementia, she knew she had early dementia, but she was very social. And this particular retirement place had a wonderful dining room. They had a fabulous chef. And this woman loved to eat and drink. She loved to eat and share a bottle of wine with family, with friends. But there began increasing problems. In addition to short-term memory, she had face blindness. So she'd meet with these people, she'd have wonderful conversations, and she couldn't remember that she'd met them before or what she talked about the last time. So that was a source of frustration for her. But meanwhile, even as her dementia, she went all over town. She took the subway everywhere, much to her family's horror. She kept losing her wallet, losing her purse, and she'd get herself home somehow. She'd call and somebody would come and get her. She lived life as fully as she possibly could. She contacted my organization. I went down to meet her with her delightful, delightful niece, who was her healthcare agent, and her recording secretary. And I told her about VSED. And I also told her about my recommendation that if she was going to consider stopping eating and drinking, really ought to have a backup plan of completing an advance directive to stop eating and drinking in case her disease progressed sooner than we all feared that it would, and that she lost capacity. So she would have instructions down there. She said, thank you very much. It was a very good conversation. She was glad to have it. She continued her life, met her friends, got lost, found her way home. And then she called me one day and said she really needed to speak to me again. I should come down because she needed to talk to me. So I met her and her niece again. And she said, you know what? She decided to hell with this stopping eating and drinking thing. She loved to eat, and there was no way in the world that she was going to stop eating and drinking. Plus, she was concerned about the symptoms that maybe couldn't be effectively palliated, even though I swore up and down that I'd get a really good hospice in there and that we'd keep her comfortable. She did complete the advance directive to stop eating and drinking, but I think she did that more because I was really eager that she do that, because I really wanted her to have a backup plan. And what she did was, even though her disease had progressed pretty far along and her short-term memory was really significant, she had a stash of medication that she had acquired from Mexico on one of her trips years ago that she kept in her refrigerator for years. And so with careful sort of written down instructions that nobody could be there with her to see that she was able to implement that, she did, and she managed it. And she took her overdose of medication the night before her regularly scheduled cleaning lady was to come the next morning. They found her body asleep on the bed, dead. Called security, called the police, who called the daughter or the niece, who was able to say she was shocked but not surprised. And she had a wonderful memorial that I was privileged to be able to attend. So she was able to manage her death in a way that was best for her, but it's certainly not an option that's available for everybody. Gobsmacked, eh, Tim?
Hang on, Tim, I muted you because there was some feedback. Let's get you unmuted.
Am I back?
There you go. Yeah.
No, I think what that illustrates is that stopping eating and drinking is going back to all the last resort options for a particular case. So again, even though you may think that one is the best fit, it may stop being the best fit, and then you go back to the drawing board and say, okay, where are we? What are the options? What's realistic? What's going to best meet this person's needs and situation? And I do think this is VSED is one option amongst six, or probably more than six, but six big categories. So you go back and rethink that as somebody gets into some different circumstance and needs a different kind of response. So I think that's why having a clinician who's got a lot of experience involved with such patients is absolutely critical. So that if they do shift gears, if they want to do something that's way different, they're able to think about that with them, explore it with them, make sure it's right for them if that's the way it goes.
It's all about informed choices, we hope.
Right.
So Arlene has a question about the death certificate. So for the case of VSED, for a person who, maybe doesn't have an illness, but they might have some comorbidities that doesn't necessarily qualify as terminal or even chronic, but she says is just tired. And they pursue VSED, what is the cause of death on the death certificate? And this is kind of a gotcha question, but curious about your thoughts.
Um, well, there are different aspects of a death certificate, right? There's the immediate cause of death, and then there's the underlying conditions. So I have put dehydration and malnutrition down as the immediate cause of death in innumerable death certificates that had nothing to do with VSED, because it's perceived to be a natural part of the dying process. And as long as somebody has some other conditions that make sense, and as long as nobody's saying what the hell happened, then it's probably going to be fine. And it's the truth. I mean, it's not 100% of the truth, but it's pretty much the truth. And so that's what I would do. I wouldn't have a big I wouldn't have a big conversation with a medical examiner. Or I wouldn't have a big conversation with anybody as long as you can describe what happened in accurate terms. Because nobody really, as long as people have a serious condition and the death makes sense medically, nobody's going to want to look too carefully at this.
And many people lose interest in food and fluid as they dwindle along with death. And so there needs to be no specific conversations about whether, in addition to losing appetite, there was a desire to hasten death. It's irrelevant. I encourage family members to not think of this as an act of suicide. Think of it as an act of slipping away, that it was time, they were ready, this is what they wanted. And I think that I know that I often get lots of questions about insurance and suicide. It's just not an issue because this is not what anybody's talking about here. Do you want to add to that, Tim?
No, I totally agree. I will say that as people are actively dying, some people will be very anxious about not getting enough food and fluids, and we have to deal with that because they're acknowledging that they're dying. And for these patients, by and large, they are ready to be dying. They're ready to be dead. So the fact they don't have much of an appetite and drink, and so it's relatively easy for them, by and large, to not do this. And we don't have to get too much into the weeds about, gee, how much of this is intentional and how much of it is natural, because it always is a mix of those things, I think, for just about everybody who's dying this kind of a death.
Yeah.
Thank you. So Lori mentioned that she's heard that 3 tablespoons of water is the maximum amount needed to maintain organ function. And she's wondering if you have any other info on this, whether to verify it or add to it. What are your thoughts?
There's no magic amount that 3 tablespoons of water is probably not going to, it may prolong things a smidge, but it's not going to be a lot. On the other hand, if 3 tablespoons becomes 3 glasses, becomes 6 glasses a day, that probably will prolong the process. So if it's to wet the whistle, it might prolong the dying process, a tiny bit, or it may not do it at all. So it's not that relevant. But if it really is, there are, and we've had cases of people who are trying to do this who really drank a lot, and it went on for literally months. Now, and they were, it was not a good situation because they were more uncomfortable than they would have been if they had eaten for comfort, and they probably didn't die any quicker. Yeah. So again, it does really, if somebody's going to do this, they really need to think through that process. And if it looks like they can't do it because they're just wanting to sip too much, you need to reevaluate and say, look, it seems like you're not ready, or that this is too hard. So this is not working. And let's let go of it. Let's see what else comes down the road. Let's go back to comfort-oriented feeding and wait for the next event to occur. It won't be that far away.
The other thing that's important is to be sure that family members know how to respond to what they perceive to be a desire for fluid. Whether it might even be a particular request. I'm thirsty, give me something to drink. I always encourage family members to give this little tiny amount, and hand that to them along with some more sedation, I think is a good idea. Not a glass like this and not filled up with ice with a straw. You own, and you never offer it again unless they're asking for it. And then again, you give the least amount that's providing comfort, but not an aggressive amount. Family members have to be trained to do that. And it's very hard for those who are of the chicken soup, thinking that you have to keep your strength up and I made this for you and you love it and it's your special and it's showing you how I love you. This is hard to let go of. And they can't do it without somebody sort of sitting them down and now let's have a conversation about what the goals are here and how we can most readily achieve them.
So comfort-oriented feeding and drinking is hard enough for many families because they want them to eat more because they want to keep them going.
Yeah.
And this is a whole nother layer than that of minimal amount that they can tolerate, because we are trying to hasten, we are at their request, we are trying to hasten the dying process.
We're trying to help them hasten their own dying. Exactly. Yeah.
Got it. Thank you. Pat is wondering, she lives in a small town and the only hospice is run by a Catholic organization. And she's wondering what the likelihood of them being supportive of VSED is. And whether if not, if there are ways to help individuals in that situation advocate for VSED.
Before Tim says anything, I would just say, do not talk about wanting to stop eating and drinking to hasten death. You talk about the fact that you don't have any appetite and you're not thirsty. Go ahead, Tim.
I would basically say the Catholics are a lot more diverse, and Catholic hospices are a lot more diverse than one might think. So if we are talking about comfort-oriented eating and drinking, any good Catholic hospice will be fine with that. Now, they don't need to know that you're doing the minimum amount. I think this is an example of where you just don't have to tell everybody everything, unless you really are somebody that you trust. And because I think they'll be fine if they view it as a more natural, it's on the natural end of the spectrum than on the willful end of the spectrum. Yeah, there may be some places that would not support this, that this would really go over the line for them, in which case you need to, if you live in a community that has a non-Catholic hospice, you may want to look at switching or not going with that one in the first place. But again, I've taken care of a Catholic patient a nun, in fact. Some of you may, I think Judy may have heard me say this before, maybe Sarah, but this was a nun who was on hospice. She was my patient, and she was really ready. And she viewed not eating and drinking as a fast for God. And she was going to her maker, and this is how she was going to get there. And who's gonna kind of override that? I mean, it was fine. And she wanted it to go faster because she was really ready for the next life. She was done with this life, and that was very understandable to everybody involved. But she framed it. We were able to collectively frame it in a way that was acceptable. So as long as if you try to frame it in the right way, usually you can work around these kinds of barriers.
I want to add to what Tim said, because I come across family members or patients themselves all the time who have exactly that situation. There's only one hospice in their county or their community, and it's a Catholic one. And they assume the worst. They assume it's not going to work. They're not going to be able to make choices that reflect their values. They're, oh my God, it's going to be terrible. And I think Tim's absolutely right. Don't assume that. Just talk about your symptoms. Talk about your goals. You don't want to suffer. You want to be kept comfortable. That's what your family wants. That's what you want. How can we best achieve that? And you don't have to volunteer whether you have any other secondary goals in hastening your death. It's not necessarily anything you need to discuss with hospice. But you do need to have a clinical partner, and you do need to have good symptom management.
Absolutely. I just want to touch briefly upon a comment that Sally put into the chat about dry mouth. And I'd love to hear what you think, Tim and Judy, on what she says. She recommends glycerin swabs, even though some patients don't like them, or a lollipop type corrugated sponge that dips into water to moisten and clean the mouth. Also keep the lips moisturized with a chapstick, kind of what you were saying, Judy, with that frozen tea towel or washcloth. And yep, and ointment or whatever the patient prefers. So anything to add to that, Judy?
I think those are all good ideas. Some of those swabby things can have a lot of fluid in them, though. And what I find is you're sort of giving mixed messages to your body. You know, if you're providing these swab things, or anything for that matter, little sips that are starting out once every couple of hours to then they're every hour to every 15, 30 minutes, you're cueing the body to want more in a way. I'm sure Tim totally understands the physiology involved here. I'm not, but it's true though. You have to be mindful of how your distressing symptoms can be managed other than by providing fluids. So, but I think that, you know, anything that you have found works with other people, try it with this person. See what works for them. Everybody's different.
I think the biggest challenge is to find solutions that don't, if somebody's really ready, that don't involve giving a lot of fluid. And that's because fluid is going to be the one thing that's probably going to provide very temporary relief, and they're going to want. And it's going to undermine the process. So all the things that both the person who asked the question is saying are good ideas, and Judy has good ideas. But this is I think this is the toughest part from a symptom management point of view of VSED, actually. You know, delirium's tough, but we have good answers for that. But dry mouth, our answers they're okay, but they're not they're very imperfect.
Well, thank you both. I want to offer you each the opportunity to give closing remarks before we conclude today. Unfortunately, we've reached the end of our event, and thank you to our audience for fantastic questions. Judy, let's start with you.
This has just been terrific. It's a great opportunity to, I'm sorry if you can hear my dogs barking. They think this thing should be over as well. I hope that it's been helpful. I hope it's been informative. I know that Tim and I share the goal. My goal is not to talk anybody into doing anything. What I really want to do is have people have enough information that's accurate and comprehensive so that they can make informed choices that reflect their values and wishes. And I think that both of these options, that VSED and also completing an advanced directive, against a future that could be worse than death to you. I mean, that's how many people look at dementia disease. The goal here is to provide comfort and some control so that the dying is as peaceful and gentle and comfortable as possible. So if we've been able to help you understand that and make it a more likely outcome for you, I'm very pleased. And be in touch if you've got questions.
Thank you, Judy. And Tim?
So I would just put VSED in the context of all the other 5 or a total of 6 last resort options, what I've called last resort options, because I think you are trying, I mean, the first stage is to make really sure this is what the patient wants and needs at this point, that they are ready to die now rather than later. And then you're trying to tailor what you do to be as responsive as you can be given their clinical condition. VSED, I think, is an incredibly important option because it really puts the ball in the patient's court, probably more than any of the others. And it does provide an option for people who might not otherwise have good options. You know, the people with early dementia, the people with very severe chronic conditions but aren't actively dying, but who are really ready to die. And so thinking through that and going through those options, I think, is very useful. Having some caution about it because it's a big decision, right? This is a life and death decision. So I do think getting the more you move away from the otherwise imminently dying patient, it is wise to think about second opinions, make sure they're sure, all that stuff. But I do think it's a very important option. And I appreciate you all sticking with us to learn about it tonight.
Well, thank you so much, Tim and Judy. Today's discussion has just been terrific, and I want to offer a round of applause to both of you for carrying the baton from last week's celebratory event with the two of you and the two other authors, Thaddeus Pope and Paul Menzel, who've authored this incredible book on VSED, which I think sets the new gold standard for clinical care guidelines. And I just want to thank you both so much for your expertise, your presence here today, your incredible contribution by being here today for the Completed Life Initiative. We're so grateful to you and to all of you in the audience. Thank you so much for your incredible questions. I know we can't hear your applause, but I hope this suffices. Thank you. And I just want to reiterate that learning more about VSED and other options within the big tent of what it means to live a completed life are available on our website at www.completedlife.org. We have a treasure trove of video archives available for your viewing pleasure. And as I mentioned at the beginning, this event has been recorded and the video recording will be available soon. So please don't hesitate to reach out to us if you have any questions via email, info@completedlife.org. And please also feel free to take a look at End of Life Choices New York website as well to get in touch with Judy. So thank you again. And I want to also shout out to our upcoming November fall conference for the Completed Life Initiative starting next Thursday, November 4th. So please keep an eye out for that, and we look forward to seeing you there. Thank you again so much, and be well.
A big round of applause to Sarah as our fearless leader. So thanks, Sarah, for
Absolutely. Well done, Sarah.
Thank you both. Thanks so much. All right. A pleasure as always. Be well.
Bye-bye.